Thank you so much. Welcome, everyone. On behalf of the NCD Alliance, the Eastern Mediterranean region, I would like to welcome you all to our session titled Prioritizing Cancer Early Detection in the EMR. I'm Dr. Ibtihal Fadel. I'm the chair of the Eastern Mediterranean NCD Alliance. First, I would like to extend my great thanks and appreciation to the London Global Cancer Week team for this invaluable opportunity to present and highlight the critical issue surrounding cancer in our region. Today, we gather to advocate for a crucial shift in our approach to cancer care, one that prioritizes early detection and screening. As we know, majority of cancer patients in our region are diagnosed at late stages, leading to increased treatment, reduced survival. Currently, the mortality to incidence ratio for cancer in our region stands at a concerning level, 70%, compared to 40% and 55% in Europe. This high ratio indicates a significant lower survival rates from diagnosed cancer in our region. However, we have some success stories in our region for downstaging in a number of countries. We have the power to change this statistic through targeted early detection efforts. Our objective today is clear: to make a compelling case for redirecting healthcare spending toward cancer early diagnosis. It is not just a medical imperative, it is an economic one. By detecting cancer early, we can significantly improve the survival rate, lower cancer treatment, and also reduce the mortality and reduce burden on the healthcare system. So over the next 90 minutes, our esteemed speakers, panelists will share their achievement, challenges, and their best practices from the country in our region. And we also, additionally, we hear the voice of a patient affected with cancer and looking forward for solution for cancer early detection. We know that the next UN high-level meeting in September 2025 is a great opportunity to advocate for cancer early detection. As association, the Eastern Mediterranean NCD Alliance, we are committed to using every opportunity to advocate, to prioritize cancer care management and early detection in our region. We believe that with our collective voices and with all this effort, we will be able to change policy and improve survival and reduce suffering for our patients in the region. I would like here to thank, before moving to session, I would like to thank our eminent speakers, panelists, and moderators for their contribution and insights. And to move the agenda ahead, well, let's start with an introduction. I had the great pleasure to welcome Dr. Asmas Hamrush. He is the Director of Non-Communicable Disease, Mental Health, Universal Health Coverage at WHO EMR in Cairo. Dr. Asmas will provide the introduction of the subject. Thank you very much, Dr. Asmas, and welcome.
Wonderful. Thank you so much, Dr. Ibtihal. Salam alaikum. Good afternoon to all of you. It's a great pleasure to be with you. And when I look at your names and credentials, I very much feel I'm preaching to the converted here. And you're all specialists. I have become a bit of a generalist. But I still believe this is an important opportunity for us, and especially at the annual London Global Cancer Week, which we are joining now for the fourth time actually in a row. And I do believe that this is an important and useful dissemination platform for all of us. And as Dr. Ibtihal kindly mentioned, I think we all see the needs. You have just mentioned the rationale really for discussing even more cancer early detection in our countries. And of course, not all countries can be represented in today's session. We have a great mix, I believe, of 5 or 6 speakers at least from 5 or 6 countries of the region. But we all know that, of course, early detection and often premature mortality especially concerns also less fortunate countries in our region. And for me, on reflection, this is one of the important reasons also why we speak today. So we allow those countries who are in conflict at the moment or who are not so fortunate in terms of the economy to still be able to do something for their populations and their people in need. So this is, I think, the deeper reason also for us to talk about early detection today. Next slide, please, if you will, kindly. So early detection, of course, includes both screening and early diagnosis in terms of testing healthy individuals for screening and detecting symptomatic patients as early as possible, on the other hand. Next, please. And of course, there's many more to be screened. And therefore, screening, of course, has its challenges, as we all know and as we appreciate. And over the years, and I think all of us have probably worked in different settings and different countries over the years, my experience having been around the world with WHO and before that in other countries in Europe, it has been a changing landscape where I must honestly say that in many countries, colleagues have become a little bit more cautious in terms of promoting screening too quickly, too easily, because I think we had backlashes, and we now know better, I think, than 20 years ago in terms of the sometimes even not only inefficiencies, but also dangers in screening too early and then, going down the intervention line a little bit too quickly. And I believe this is an important part of our discussion. A lot depends on the setting. A lot depends on the population-based comprehensiveness of our programs, on our quality control, and the resources and the systems that we have. And yet, of course, screening in many settings, especially well-resourced settings, remain a very important, what I would call gold standard. Next, please. So we all know that early diagnosis is maybe as important to discuss because it is applicable for almost all cancers. It is simple to implement in many settings, even in resource-poor settings. It can be an integral component of national cancer control programs, and it's also cost-effective if it's done properly, and therefore also included in the WHO Global Best Buys for preventing and controlling NCDs. And at the same time, screening can be effective if it's done properly in well-resourced settings, often with strong programs and population-based approaches. It needs, of course, careful consideration, as said, including financial availability and sustainability. And when done properly, it can yield great results. So we also want to always keep it in the gamut. But as I said earlier, I believe we have become a little bit more careful in terms of, applying it in every setting. And of course, and that's really important, the ethical considerations of early detection considered unethical where treatment services unavailable. And I do remember my time in East Africa after the conflict in Rwanda, and that's almost 30 years ago now, where we were in that situation, at least for some time, and it was a real dilemma, and it cost me a lot of sleepless nights and my colleagues. Next, please. So we all know that early detection is critical in cancer programs. It does yield potentially better health outcomes and certainly reduced financial burdens. But the devil often lies in the details. As we say, we have to look at the data carefully, the epidemiology, the resources, the systems, the capacity, and then it can become a very important component of our work. And if I may take this opportunity also, and we'll come to that in a minute, to advertise again. I don't know if you can see that properly on the screen, but there's actually a lot of important standards available now in WHO, including in our region, and within the guidance that we give to all countries, including in EMRO. Of course, early detection is an important component next to governance, prevention, management, palliative care, very importantly, and surveillance and research. So it really is an integral part of our guidance now around the world and around the region. Next, please. So we've talked about challenges. There are delays. They all depend on, ability of patients to access us, of us providers to reach out to patients, and then being able to administer the right treatment. And we all know the delays. We all know the challenges. And we have to, I think, be realistic, and base our programs on real issues in terms of the finances, the logistics, and sometimes also cultural and psychosocial barriers leading us into difficult situations. And I believe that's especially the case also in emergency settings, in settings where countries face, access issues, especially also due to conflict and sanctions, and oftentimes also very much a maldistribution of services, where services are available in big cities, but not in rural areas or unsafe and insecure areas. Next, please. So what's the status of cancer screening? And next, please. I beg your pardon, we're just selecting a few cancers. And when I think I used the same slide, a few weeks ago in Qatar in a side event on breast cancer, I was kindly reminded that even those figures, which we have, of course, got from our countries, we don't maybe have necessarily the very latest information. But I think it is a useful overview for some of the countries in EMRO that have provided data for us in a recent survey, where we see that there's a mixed bag in terms of, applying mammography and/or clinical examination and ultrasound, and, the way it's organized throughout the system, or opportunistic. And I think it's basically a reminder of the great differential of socioeconomic in situations and scenarios we face, and we all know the huge differences that are there. And I think we have a joint responsibility to always keep the the Somalias and rural areas in other countries in conflict in mind when we plan programs, and perhaps build that into our programs in terms of, components for neighboring countries that can be helpful. And when it comes to breast cancer, of course, mammography is the gold standards. It is in rich settings in certain age groups, as mentioned here, repeated relatively frequently, but it is constantly changing also in terms of what systems can provide. I believe it is an area also where mammography will and maybe done by technology, including AI, more in the future. So it's a place to watch, and where we have to constantly compare notes and check the best and the latest evidence, I believe. And at the same time, in limited resource settings, of course, self-examination remains really important and can save lives where those mammography services are not available. And unfortunately, there's large areas and terrains in countries where they are simply not available. Next, please. When it comes to cervical cancer screening, I think there's now good evidence and long-standing evidence of what works and what can be done with pap smears, of course, in the past, but now also a changing international experience and landscape with more and more countries introducing HPV vaccinations and therefore also adapting their screening programs for individuals. And so again, I think it's a very dynamic landscape where, the experience from individual countries and beyond the region is really important to get the best and the most cost-effective intervention into the particular context. Next, please. We have, of course, colorectal cancer as a common cancer in both sexes and also in men, where we have the occult, blood tests available in many settings. But I personally do believe, and I've had the privilege to work in 5 WHO regions now, that around the world, in many settings, including settings in EMRO, proper routine rectal examination is not done enough for many different reasons, but I think it's always painful to miss, colorectal cancers, which are commonly and easily detected, in the majority of cases, of course, through proper rectal examination. And we are missing many opportunities, I think, including in general practice, but also in other settings to do those. So I think more lobbying and destigmatization needs to be done here. Next, please. And then the interesting and important and complex issue of prostate cancer screening, where I believe that, PSA screening has been, or results have been disappointing in terms of false positives and over investigation, sometimes even over treatment. And yet, of course, it has an important role to play, again, if it's properly complemented with, transrectal ultrasound where possible, but also the good old and very important experience of somebody who can do proper rectal examination for it. So again, I think an area that is underutilized in many settings and yet could do a lot of good if applied and promoted properly. Next, please. So all this, as I said earlier, is now well published globally in the WHO, some of our partner agencies, especially IARC and the IEA. And there's a wealth of information available, more and more publications also harnessing experiences from around EMR countries. And I would like to encourage you to study them. Most of them are easily available on our website. And of course, and especially share your publications with us so we can harness them and disseminate them further. Next, please. So just one final word on opportunities for increased support. And that's something that is often not known in all countries. As I just mentioned, we have a strong partnership with other UN agencies, especially our International Agency for Research in Cancer in Lyon, France, but also the International Agency for Atomic Energy, with a large and long-standing program for cancer control, especially supporting countries around the world and around the region with radiotherapy programs. We also have UNIT-8, a kind of UN entity that works, especially in disseminating equipment, for countries and facilitating that. And we have powerful partners, including the Islamic Development Bank, which is very willing and able to invest in cancer control infrastructure. And you all know examples. I believe we can also do even more, a complementary work with them. And we depend on you in countries to also flag up to us and to those other partners, our comparative roles, perhaps, that we have to play in supporting country programs. So I very much encourage that collaboration. Next, please. And I think that's the final slide almost. So we all know early detection saves lives and saves money. And it is really important to talk about it. And yet, you know, every country is different. Often settings in countries are different. And therefore, the gold standard of population-based screening is not always available everywhere. But early, you know, detection is available and possible everywhere, with early diagnosis playing an important part in especially resource-constrained settings. Of course, everything must be embedded in then the follow-up, and this is often where we're losing patients, of course, for different reasons, sometimes even cultural reasons or stigma. And that's also very painful for us to see, I think, as professionals. And at the same time, I believe, as was just said, that we are not fully harvesting all opportunities for collaboration and also for flagging up those issues with the right sources. Oftentimes, in my own experience, I think we're missing opportunities in terms of upstream. And what I mean here is that we often have champions beyond the health sector. They're often high up in government in terms of spouses or, you know, part of the upper strata of society, including royal families and presidents' wives, you know, actors or other prominent people who would be very willing to be our ambassadors, but who have not been yet fully approached. So I would very much encourage that as well. I've seen it working in a number of countries, including countries in EMRO now, but very much beyond that also. And I think this is where we all have a role to play. So last slide, please. I would like to thank you very much for inviting us again. I would like to thank all the colleagues around the call. You're really the experts. I'm one of the facilitators with my team, but I'm very happy to be here for the 4th time and look forward to many more opportunities. Thank you. Shukran.
Thank you very much, Dr. Asmas, for your leadership and commitment. Indeed, many of our colleagues now will be speaking about the situation in countries, and thank you very much. Now I want to hand over to our first panel moderator, Ms. Reem Al-Ajlouni. She is the director of Jordan Breast Cancer Program from Jordan. So welcome, Reem, and over to you. Thank you.
Okay. Thank you very much, Dr. Tihal. Can you hear my voice?
Yes.
Clear. Thank you.
Okay.
Yes, very well.
Okay, thank you, Dr. Tihal and Dr. Asmas, for the introduction. Welcome, everyone, to our session today about strengthening cancer early detection systems in the Eastern Mediterranean region, progress and challenges. It's really a pleasure to be with you and to be joined by such distinguished speakers, world-renowned leaders in the field of cancer control. Allow me to introduce our distinguished panelists, Professor Hisham Al-Ghazali from Egypt, Professor Samar Lahmoud from Saudi Arabia, Dr. Debra Mukherjee from the United Arab Emirates, and Dr. Nareen Zafar from Pakistan. I'll introduce you more in depth when we start the discussion. But for now, as you know, cancer is a significant health challenge in the Eastern Mediterranean region. As mentioned by Dr. Tihal and Dr. Asmas, sadly, the majority of cancer cases in our region are diagnosed at advanced stages. This delayed diagnosis not only affect patient outcomes and patient quality of life, let's say, but it put a heavy burden on our healthcare systems, as late-stage diagnosis is costly and complex. However, from research and from global experiences around the world, we know, and it has shown, that prioritizing cancer early detection and screening can make enormous differences. And this is what we will discuss today. We will focus on strengthening the cancer early detection in our region across the EMR. We'll explore progress made, challenges that we still face, strategies needed to overcome the barriers. Through the speakers, each one over the next 25 minutes will share insights from his own country and from his own experience. I'm sure that their expertise will inspire new ideas and collaboration. Without further ado, let's get started with our first speaker, Professor Hisham Al-Ghazali. Professor Hisham is a is a professor of clinical oncology at Ain Shams University in Egypt, and he's the head of the Presidential Initiative of Women's Health. Professor Hisham, how does Egypt Initiative manage to enhance breast cancer screening? What were the main enablers and main barriers from your experience? Over to you.
Thank you very much, Dr. Reem, and thank you very much for Dr. Ibtihal for inviting me for this very important meeting that allowing us to share experiences, try to discuss about the gaps, how to improve. And I feel it is very, very important to discuss all the issues, especially in very large country like Egypt with a huge population, more than 110 million population. And with also, again, it is low middle income country. So it is very important to know what are the gaps, how to go for, what is the success story that we want to tell about. And we shared this before, but I want also to share my slides if you allow me. I don't know, I sent it to Dr. Ibtihal. I don't know if we can share it from your side or not.
Sorry, we didn't receive a slide. If you want to speak to the slide, I mean, if you cannot share it on the screen.
Dr. Hisham, I think as a panelist, you can share screen.
Okay.
I think you should open it at your desktop and then share screen. And
you can share screen, Professor Hisham.
Okay, I will try to share it now. I think it's shared now.
Yeah.
Yes.
No, not this one.
You stopped sharing, Doctor.
Okay.
They appeared and then disappeared.
Okay.
Yes, perfect.
Okay.
Yes.
Okay, so let us go for this barriers, achievement, and future plan of the Egyptian Presidential Initiative on Women Health. And we all know, as mentioned by Asmus, the challenges and barriers that we all feel, that the low health expenditure, fragmented health sectors, inaccessible to diagnostic and treatment services, lack of well-trained working forces, social barriers and the stigma and others, especially the women in our countries, large population in Egypt, and also the minimal representation in the global clinical trials and inadequate positioning. And here is the national strategy of Egypt, and depending on main statement, including the equity, non-discrimination, efficiency, quality, and accessibility. And I think, as mentioned, usually the main success elements is the political commitment for this initiative for women cancer control, and the integrated approach, including accessible healthcare services, cost-effective and value-based services, technical assistance to build a resilient system, capacity building for individuals, and pathology and radiology, and also time commitment. And all this initiative is patient-centered approach and depending on KPIs, depending in the global breast cancer initiative KPIs. So in this important initiative, as mentioned by Asma, that Egypt is a very huge country. So it is not very easy to go for mammography examination, how to reach all these people in the south, in the north, in the east. So we are depending on the primary healthcare units, more than 3,500 primary healthcare units in all over Egypt. And we try to be the nodes of the clinical breast examination, go for, as you see, training of a huge number of healthcare providers, more than 30,000 healthcare providers, including nurses, doctors, radiologists, pathologists, oncologists, data entries, and social workers, and also building a digital system that helping to connect all these nodes together to be centrally located in the Ministry of Health. So like aggregating all data from all over Egypt. And then when you go for the clinical breast examination in the primary healthcare unit, if there is something suspicious, we refer them to tertiary examination in more than 110 hospitals. And then again, if there is something suspicious, going for mammography and ultrasound assessment, biopsy, if we suspect these lesions, and go for MDT for the first time mandatory in all the hospitals in the Ministry of Health and the Ministry of Higher Education. Also, we go for capacity building, as you see, with international partners, including Northwestern, Louis Bernard, and also we have improving during the journey starting to 2019, improving the capacity of the radiology assessment, improving the capacity of pathology assessment. We started in the 2019 by only 35 mammography machine, and this improved by time to 177 mammography devices distributed all through the governorate, and also upgrading the 12 mobile mammography trucks to try to go some areas with like personalized approach, like the New Valley, which is very, very remote area with 1,000 kilometer long. So it is important to go for some mobile van to try to go for picking the mammography assessment. Also improving the capacity of pathology, as you see, starting with the first ever CAP accredited pathologist lab in our country in the Ministry of Health. This is the great, and we are proud to announce these beautiful outcome and numbers, and the total offered services in Egypt is more than 54 million visits for the woman, with more than 22 million women screened and by clinical breast examination. Total examination in the tertiary hospital is more than 740,000 total examination in the hospital. Total radiology assessment is almost 395,000 total radiology examination, and total pathology test more than 45,000 total pathology examination. And now we have confirmed cases of breast cancer is more than 30,000 breast examination early detected. And the number of cancer patients also followed up that going and joining the program is now almost 111,000 patients. We talk about the capacity, and I'm very happy with the statement that Asmus mentioned, that if you go for early detection program without treatment, it is unethical. So we build our protocols, treatment protocol after the MDT. So we go for this treatment protocol, including the pathology, including the radiology, including the systemic treatment, including the surgery. And these protocols is also depending in two other independent bodies, called the UPA, which is independent bodies trying to have bulk prices and the localization of the medication to improve the access. The EDA, which is the Egyptian Drug Authority, which go for cost-effective studies and budget impact study, and all of these helping to increase the access and helping for localization of treatment in Egypt. And really, again, we are very, very happy and proud that we achieved the 3 pillars of the Global Breast Cancer Initiative by decreasing the stage 3 and 4 from more than 70% before 2019 to only 20% now, and also decreasing the time for diagnosis from more than 120 days to only 49 days. And now almost all the hospitals in the Ministry of Health and the Ministry of Higher Education obligated to go for MDT or comprehensive breast cancer treatment approach in all the hospitals. Not only
Dr.
this,
Hisham,
but also, not
One
only this,
minute.
but okay, not only this, but also improving the economic outcome. So this is the cost effectiveness with ROI is 38%. And the international collaboration, as you see, with the IARC, with the WHO on EMR, and these are some of them. Future plans is going for the Egyptian big data informatics and artificial intelligence. And lastly, integrating for her, so integrating locally and integrating internationally. Again, thank you very much for this opportunity. And we're really happy to have all collaborating together to have better outcome for the women in the region and worldwide. Thank you very much.
Thank you very much, Dr. Hisham. And really, the progress made by the presidential initiative on women's health is remarkable. Yesterday, I have seen the news about the Solidarity Day you have organized. It's great what you're doing. So thank you very much for all your efforts. Let me move to Professor Samar Al-Mahmoud from Saudi Arabia, the Kingdom of Saudi Arabia. Dr. Samar is a consultant colorectal surgeon at King Faisal Specialist Hospital and Research Center. She's one of the first Saudi females to practice colorectal surgery. She's a member of the advisory board of the Cancer Screen 5 project. Dr. Samar, how have colorectal cancer screening been implemented in Saudi Arabia and the Gulf area with the GCC? Potential for organized screening program and key challenges you have faced.
Bismillah ar-Rahman ar-Rahim. Thank you very much. I hope you can hear me well. Thank you very much,
Yes.
Dr. Ibtihal, for this honestly very hopefully fruitful meeting, and for Ms. Reem. And I hope not only we have this meeting, our collaboration will extend after this meeting, and we can come up with some, data or guidelines. Regarding colorectal screening, it's not. It started later than breast screening in the GCC countries. For example, in Saudi Arabia, the first pilot was started in 2017, and Qatar was before that. If I might share.
Yes, please, Doctor.
Yeah. Just a couple of slides, not a full presentation. Can you see my slide?
Yes.
Yeah. So this is one of the papers we presented in the Lancet Oncology a couple of years back, and it was a product of one of the London Oncology Week, and I hope we can gather with another paper, all of us together with the EMRO region. And if you can see the majorities of the screening between 45, starting from 45, and most of it is a fit-based testing. Kuwait is a colonoscopy based, and it's mainly an opportunistic through self-referral or going through the primary healthcare sector. To be honest, from 2017, there is a major improvement with the colorectal screening using the FIT test, but challenges still remain. Some of those challenges, I think we don't have our current data of uptakes. What is the targeted population in order to build up this to a population-based program? as well as the recalls and positivities and so on. So I think the main issues, we are heading toward the right direction. But I think the most thing that we really need to work on is the early diagnosis simultaneously with this. I think we are heading the right directions, and this will be of use 15 or 20 years down the lines, because so far we are unable to identify our targeted population. And we are a young populations in the GCC. 60% are below the age of 40. So initiating such a program from now will definitely help us when we have the peak. But if I may go back one slide earlier, is our current diagnosis. Still, we have 50% of our cases is whether they are regional or distant metastasis. If you can see overall, this is 2021. Our localized has improved. 10 years ago, it was only 20%. And now with the better detections, with the better awareness, we managed to increase localized colorectal screening up to 40%. And I think this also need to be more. I think we really need to improve our early diagnosis. Dr. Ismas just raised up a simple as when you do per-rectal examinations, raising up the awareness among healthcare professionals, not only the populations where personally, I tend to see a lot of cases, they underwent hemorrhoidectomy without a proper examination, and their main complaint is cancer. So I think we really need also to assess our current early diagnosis strategies with regarding to, timely referral, timely starting on treatment, our capacity building, and we need to highlight those and have a main KPIs in order to, have a future plan or improve our current plans. I think this is some of the recommendation we came up with this paper, which I think it's implied in most of the screening. We need to improve our survival data. I think all the EMRO regions, we have a major issues with the survival data, and there is a lot of initiative now in the Saudi Arabians and the Gulf GCC, along with IARC and so on, to working on improving on having our survival data. Invest in establishing and developing cancer diagnosis and treatment infrastructures, engaging private sectors, enhance timely based and affordable treatment. We need, as I said, a key indicators and metrics to monitor and evaluate our quality of our current programs and their effectiveness, as well as the early detection program. I think the most important is a timely access to cancer care is very important. And I think it just needs reorganization and capacity building and so on. So I think we are heading into the right directions, but I think we have more effort to go with such strategies. I think one point also is increase awareness among our population, as well as improving the risk factors, including the healthy lifestyle. Unfortunately, in our regions, the unhealthy lifestyle is picking up compared to Western regions with obesities, increased smokings, and so on. And there is plenty of efforts from the government, like taxations on tobacco, healthy meals on schools, having calories now on. This is already implemented in Saudi Arabia during on foods and restaurants. So we are heading into the right directions, but I hope there's still more challenges, and I hope through such meetings that we can finally to conclude, we can have our own currently data. We don't have any data regarding the current situations of cancer screening in the EMRO and in the GCC. I'm more than happy to lead this with you or colleagues so we can address the challenges. Thank you.
Thank you very much, Dr. Samar. Yes, as you mentioned, you're heading in the right direction. At least you have started. Colorectal cancer is among the most common cancer. And what I have noticed that in all the GCC, services are available at the primary healthcare level, which is great. This is what we need, more early detection at primary healthcare level. Let me move to Dr. Debra Mukherjee. Dr. Dibra is a consultant medical oncologist at the Clemenceau Medical Center, United Arab Emirates, and adjunct associate professor at the American University of Beirut. Dr. Dibra, what advancement do we need to see at health system level for early detection of cancer, with example from your area of work?
Thank you so much for this invitation to join this wonderful panel and to discuss this incredibly important topic. Your question is very difficult because we have such a diverse region in the Eastern Mediterranean, from very low resource settings, crisis impacted settings, conflict impacted settings, to very high resource settings. And I think having had the privilege of working in some very different healthcare settings, I certainly don't have all the answers, but have had some limited experience in these different areas. So I think that we have an opportunity, particularly where I work now in the United Arab Emirates and the GCC, to really embed cancer early detection and cancer control in NCD control in general. And this doesn't necessarily work in Western populations, but I think in our region, we really have this opportunity to make a solid investment case for embedding cancer control within the broader NCD control. And Professor Samar very importantly mentioned some of these lifestyle aspects, some of the policy changes that we're seeing to really look at NCD control as a wider issue. We have an aging population, and an aging population means that we're going to see not just an explosion of cancer incidence, but also all the other NCDs and comorbidities that go towards that. And any healthcare system is going to have to deal with that as an ongoing issue, and particularly in the GCC region where, as Professor Samar really had that great introduction, we have a young population with 60% under the age of 40. So imagine what's going to be happening over the next 20 years as our population ages and our health systems are going to have to deal with not just cancer incidence rising, but everything else. So I think the first really disruptive approach is going to be embedding that policy of NCD control into general health system strengthening. And I don't think that we can separate these. The issue of universal health coverage is a dream that's not going to happen in the whole of the EMRO anytime soon. And I think putting together all the strands of public-private partnerships, using policies that are going to embed all of those different technologies that we can now use to inform healthcare systems in a very flexible way. And what does that mean? That means using all the data that we have, not from the traditional methods of waiting for 5 years for your tumor registry to come out with a report, but it means gathering data in real time from healthcare systems, from electronic records, from pathology reports, and actually working out where the interventions are needed and really making that strong investment case for cancer control. And that means at the policy level, so that means, as Professor Samar mentioned, taxation, incentivizing healthy lifestyles, but also the economic basis for cancer control as saving money in young, healthy working populations. So there have been multiple strategies that we've looked at, and a lot of these investment cases actually have come from WHO offices, but mainly focusing on NCD control. And I think we need to expand that to cancer control, particularly in young and working populations, but also to make this very gender sensitive. We haven't got to forget the majority of young women who perhaps are not in salaried positions, and factor that into our investment cases. So we need to make sure that we're not just looking at men with salaries, we're looking at women and their caregiving roles and factoring that into our investment cases. We've seen fantastic data from Egypt and Professor Hisham about this incredible return on investment in the population looking at breast cancer control in Egypt. And I think there are many examples that we can use to look at how each country can very flexibly look at their population, their workforce, their investment in cancer control, embedded in NCD control at all different levels. So you asked for some examples, especially from the United Arab Emirates. And we have some very important public-private partnerships working with NGOs, working with private and public hospitals to try and strengthen at ground level the issue of early detection and awareness, because unfortunately, even for a high-income country, we don't have the opportunity to have population-based screening or call and recall systems, mainly because of the fluidity of the population and the very fragmented healthcare systems that we have, with the majority of healthcare being delivered to expatriates rather than UAE nationals, on a very fragmented level between the different departments of health, private healthcare providers, and also traveling externally for cancer care. So this makes the situation extremely complex. But I think within the WHO EMRO region, our young population, we have a huge opportunity to look at some very innovative and impactful ways of embedding cancer control into general NCD control and really making that an economic investment case for moving forward.
Perfect. Thank you very much, Dr. Debra. You have touched on different health policy issues. As you mentioned, cancer burden is growing, particularly with aging population, and without embedding it and integrating early detection and screening within overall health system strengthening initiatives and non-communicable diseases initiatives, there's no way forward rather than integrating it and utilizing the commitment towards universal health coverage. Thank you. Moving now to our last but not least speaker, Dr. Noreen Zafar from Pakistan. Dr. Noreen is a consultant obstetric gynecologist, founder and president of Girls and Women's Health Initiative, and she is the WHO advisor for cervical cancer. Dr. Noreen, as WHO advisor for cervical cancer elimination, what can be done in your country, Pakistan, for promoting early detection of cervical cancer?
Thank you very much, Ms. Reem, for this very generous introduction, and a bigger thanks to Dr. Ibtihal for inviting me to share this stage with such a learned group of people like yourselves and the audience. I'm truly humbled by this. Thank you. Actually, I was just going to go through a few slides, just set the scene of what is happening in Pakistan and EMR in context of cervical cancer, if I may do that. Can you see my screen, please? Right. Okay. So cervical cancer is one cancer that doesn't need to be anymore because we know what causes it. We can pick it up in the clinic in a pre-cancerous phase. Even if you pick it up at an early stage, it can be completely cured. But still, it is killing our women like flies. Even in just EMRO, one woman dies of cervical cancer every hour. And in Pakistan, we've just done a situation analysis for breast and cervical cancers. 14 women are dying from cervical cancer every day. So that's a Boeing 777 crashing every month. No news about it, nothing. And this is a cancer which can be completely eliminated. And the worrying thing, like it has already been shared by my worthy speakers, that Pakistan has a population of about 64 million girls and women aged between 15 and 44, all at risk of cervical cancer. And then, with the changing reproductive practices and traveling, smoking, the incidence is going to be really, really high. And then we have been looking forward to this WHO initiative, which started from January 2019, and then the the EMR strategy for prevention of cervical cancer, which accounts for the socio-cultural and restrictive resources like ours. And when we look at the entire situation in Pakistan, there's a whole lot of interplay of factors which are responsible for this misery, which can be completely prevented. So, as we look at things in context of Pakistan and generally in EMR, the most important thing is that women have to take charge of their own health. We have to redefine cancer. We have to get rid of the stigma. We have to reach out to men, women, families, mother-in-laws, school teachers, policy makers, religious leaders, politicians like Dr. Asma suggested earlier. And then also I know our country is a poor country. We are, suffering in all manners, natural disasters, man-made disasters. But actually, this is something that can be dealt with, but we have to get it across through all possible ministries, finance ministries, the law ministry, the education ministry. Until and unless we have the top brass willing to do something, the situation will never get better. And then one significant problem that we have is monitoring, governance, evaluation, accountability, and a judicious use of resources. We have a setup whereby there are basic health units, and then there are tehsil and mid-level hospitals, but the shifting and task sharing has to be implemented because the doctors cannot be everywhere. So we are hoping to start a basic cervical cancer screening using single see and treat with visual inspection with acetic acid, and incorporate it into the primary healthcare system, because there are lady health workers and community workers which can be taught to do the visual inspection with acetic acid. The only dilemma we are facing at the moment is that WHO recommends HPV testing, and to actually preach to the government to switch over 360 degrees completely to a totally new test is something that we are struggling with at the moment. But we are hoping that we can learn lessons from like Kingdom of Saudi Arabia, Morocco, Tunisia, Qatar. So much has been achieved in the Eastern Mediterranean region. So we are hoping that with surveillance, with generating our own data, like Dr. Deborah just said, and using artificial intelligence, telephones, WhatsApp, we can reach out to women, train the healthcare providers, and at the same time generate our own data, which will be helpful for us to get rid of this menace. And I hope that our next generation will be able to actually witness the elimination of cervical cancer. Thank you very much.
Thank you very much, Dr. Nareen. Yes, that's great. As you mentioned, like cancer control challenges are multifaceted, way beyond than just availability of services. You mentioned some cultural and social. We have also economic and maybe political challenges. So that's why policy actions should be different. By this, we have came to the end of our session. Thank you very much for joining us. Thank you very much for our distinguished speakers. We have covered cancer early detection in the EMR, talking about breast cancer, colorectal cancer, cervical cancer, and investment case for cancer control in general. I'm sure that this meaningful exchange will hopefully drive us closer to a future where early cancer detection is prioritized, accessible, and more effective in our region. Thank you very much. And moving now to our next session. Thank you. Dr. Ibtihal, over to you.
Thank you, Reem. Can I hand over to Dr. Hadi, please? Dr. Hadi to moderate the panel 2. So we can't hear you, Dr. Hadi. Are you muted? Dr. Hadi from Qatar Cancer Society. He is the policy head of.
I'll text him or call him now.
Yeah. And just when he comes back, I would like also to thank the speakers in panel 2. So this panel will be focusing on country experience and best practices in the country, in the region, talking about their progress as well as our challenges. Back to you, Dr. Hadi.
Thank you so much, Dr. Abtihal, and it's a pleasure to join this important that panel focusing on the cancer detection and screening, which is it's a highly cost-effective initiative in areas in cancer control, and it's a pleasure to be also. Thank you, Dr. Abtihal, and to be part of this important panel of the London Global Cancer Week. And it's my pleasure to be introducing major speakers from the respective countries to go over cancer detection, country experiences, best practices. And it's my pleasure and honor to first start with Dr. Qurush Atimad. Is the Director of Cancer Program and Minister of Health in Iran. So, Dr. Qurush, I want to ask a question about the current status of cancer screening program in Iran. How's the early diagnosis managed in Iran, and what area could be potentially improved in this program?
Salam alaikum. Thank you very much. And thank you very much for inviting me from you, Dr. Hadi and Dr. Iqtihal. It's my pleasure to sharing our experience and better for me and my country to learn more from other scientific experience and national success from other countries. In our countries, Islamic Republic of Iran, as a general, there is general population more than 80 million people, and we have some variety from our demographic and access to public health. And in this way, we targeted 3 major cancers: breast cancer, colorectal cancer, and cervical cancer. According to incidence of this cancer, and monitor to cervical cancer as a problem that may be arise in the future in our country according to prevalence of HPV. In order to extend the coverage of early diagnosis and better screening of cancer, I want to share with you our experience about colorectal cancer. We integrated all cancer screening, especially colorectal cancer, as a basic benefit package for all our services in the PHC, with a unique strategy for the rural and urban area. And based on this strategy, all people access to first screening for the colorectal cancer that is started with for people who are more than 50 years old with a fit test. But for better or improve the compliance of all people and our system to improve their activity, we defined some indicators and targets based on incidence of colorectal cancer and based on the capacity of health services. This indicator contains of input indicator, process, and output, and cover the quality of screening. For example, how much is the coverage of first step of cancer screening? How much is the positive cases of the first step of fit test? Next one is how much of is fit test positive has been visited by GI subspecialist and did for them colonoscopy, and how much of them has been positive, and etc. In this way, we monitor and guide all region of our country and to give them feedback and to help them to better quality of screening. In this side, we started to educate and improve the health literacy, especially for people who have or who live with colorectal cancer in their family, because their companions for giving learning education and participating screening is better than or other population. Another strategy that we use in our country is that the 30% of hospital capacity is specified just for referral system, especially for screening cases. In this way, 30% of, or for example, colonoscopy, mammography, and all of these imaging and paracriminality are gathered to help the better screening for colorectal cancer. Another strategy that we have, we passed a regulation in our government and parliament that for physicians who accept the people from referral system, especially for a screening system for cancer, or government paid to our physician and nurse and staff 2 times as another way to improve the acceptance of patients from our services and physicians. In this way, we try to reduce the waiting list for the screening for next steps. And we try to another strategy. We try to give some consultation with from a psychiatrist from each of our
Sorry,
centers.
Dr. Qurush, if you could just wrap up, if you don't mind.
Can I continue, Dr. Badi?
Yeah, you can continue. Just, I mean, if you could wrap up, yes. Yeah.
Okay, okay. And we give them services, but psychiatrists to better control the and participate and lead with their disease for cancer, especially after treatment, in to improve through palliative care with help, receiving help from psychiatrists. Another strategy that we use is with insurance system. We deal with our insurance system, and they accept that 5% of insurance budget should cover and specify for just prevention in for NCD. And this 5% of insurance resources is a very huge resources to better prevention of disease. Especially, we wanted to focus on cancer, especially colorectal cancer in our countries. Another one is active follow after discharge from hospital. We conducted in some university and province the units that followed by nurses after discharge of cases from hospital, or nurses follow cases. And any comment, Adi?
It's 6 minutes already, so if you can wrap it up at the final point, so we have time for yes.
Okay, thank you. Finally, because the compliance of general population is low, we are changing to targeted cases for screening, especially people who have cancer and their family. Thank you very much for inviting me in this meeting. It was my pleasure, and I'm waiting to learn more from my colleagues from other countries. Dr. Hadi, floor is yours.
Thank you so much, Dr. Qurush. And now it's my pleasure to introduce Dr. Lubna. She's the Director of Cancer Program, Minister of Health in Morocco. Dr. Lubna, my question is for you is about how Morocco is managing to enhance cancer screening, and what are the main enabler or barrier for that regarding the cancer screening in Morocco.
Thank you, Dr. Hadi. In my turn, I would like to thank Dr. Ibtihal and all the organizers to invite me to share Moroccan experience in setup and also in strengthening of the early detection program. In fact, in Morocco, since 2010, which is the date of launch of our national cancer plan, from the beginning, breast and cervical cancer were the most common cancer in females. So they were the priority of our national cancer plan through the setup of early detection program. So we start by the analysis of our health system organization, and I think it's one of the most key success in our country. That's our organized program was based on a real analysis, and the standards and all the organizing components were really based on a reality of the health system or organization. So a considerable efforts have been made since 2010 to improve the management of breast and cervical cancer, and also to succeed in the downstaging for those two cancers. Thanks to the political commitments for the Moroccan government, we achieve lots of things like the integration of the screening program into the primary healthcare. So all our healthcare centers provide this screening, the identification of standardized screening program pathway to provide all the system, the screening, the early diagnosis, and the case management, strengthening the screening equipment coverage. At the beginning, we do have not enough mammogram and also colposcope to do cervical cancer screening. Currently, we have a very good coverage of these equipments. The capacity building also, we do more than 4,000 health providers who were trained to the screening techniques, and also the implementation of quality standards. And we have also a very good partnership with NGOs and social society who work with Ministry of Health to enhancing the awareness about early detection. For the other side of the question, which is are the challenges. Currently, we in Morocco, we adopt all the objectives of the Global Initiative for Breast Cancer, who launched with the WHO, and also the main objective and aims of the cervical cancer elimination strategy. So we are working hard to try to reach all the objectives. We have also a very good opportunity here in Morocco, that we are on a big refront or reorganization of our health system, and we are working to have the health insurance coverage for all the women and all Moroccan population. So we think that it would help all women to reach and to beneficiate to the screening program. I think it's the most important challenges that we have is to succeed our refund and to go ahead in our program.
Thank you so much, Dr. Lubna, and I really admire the work that you are doing into the integration of cancer screening in the whole primary care. And we are all looking forward to the reform of the health system in Morocco, and I'm sure and increasing the coverage and the access more than it's already available now. And really, this is something we are looking forward to it. And now it's my pleasure to introduce Ms. Reem. She's the Director of Breast Cancer Program at King Hussein Cancer Foundation, Jordan. And Ms. Reem, my question is more related to the strategy that Jordan breast cancer program implemented to improve cancer screening rates, and what are the factors that have facilitated or hindered their effort? Mike, it's all to you.
Yes, thank you very much, Dr. Hadi. I'll answer your question quickly, sharing some slides to introduce what is Jordan Breast Cancer Program. As you mentioned, the strategy that helped us, the enablers, and some of the challenges. Quickly, Jordan Breast Cancer Program is a national program working in Jordan, established in 2007, led by the King Hussein Cancer Foundation and Center and the Ministry of Health. It aimed to downstage breast cancer from late stages to early stages. As Dr. Asmus mentioned, there are two approaches for early detection.
Sorry, Ms. Reem, could you make it slideshow? It will be,
Okay,
you can see it more. It's not slideshow.
Okay, sorry.
No
Two approaches for early detection. It's either the population-based screening or the early diagnosis. At the time of initiation for this program, Jordan opted for early diagnosis. Now we have the early diagnosis approach with also the opportunistic mammography screening. It's the only multidisciplinary national program in the area of cancer control, and it has proved itself as a cost-effective national collaboration success story. The strategy that enabled us to expand screening, or particularly breast cancer screening and early detection, is being holistic, context-tailored, evidence-based, and the real and effective community engagement and stakeholder engagement, where we work with everyone. Our program is holistic. When I mention holistic, it's holistic in terms of programming, in terms of areas, covering all the areas and alleviating all the challenges that may face early breast cancer early detection, and holistic in terms of also of partnerships and stakeholders engaged with us. We work on three main pillars: creating the demand for breast cancer early detection through working with the community, with the public awareness, community outreach. We have the widest community outreach in the country, with health educators and community health workers working across the different governorates of Jordan. After increasing the demand and improving public awareness, the health system strengthening arm, which means to make breast cancer early detection services available, accessible, and of high quality. And under this, we have several initiatives, including training healthcare providers, quality management, developing national and standard guidelines and SOPs. We have mobile mammography screening to provide screening for underserved areas and for underprivileged women. And we work with the private and with the public sector to make sure that their services are accessible. Now in Jordan, we have more than 95 breast imaging units. That number was like around 13 breast imaging units before the program, or in 2010. We have managed to have more digital mammography machines across Jordan. The third pillar, after creating the demand, ensuring the supply of the services, is to create enabling environment through advocacy, policy, and research. And we work across the different levels, from grassroots reaching to policymakers and decision makers, to make sure that everyone supports early detection. So this is our strategy, is to work with everyone across the board, being evidence-based and meaningful community engagement. We focus on different, let's say, themes: strategic partnerships, local, national, and regional, and international; capacity building. We invest in human resources. We believe that we have limited resource. We're living in limited resource settings, but with our human resources, with the capacity of human resources, you can overcome all of these challenges. We aim to increase screening. It's not population-based screening, but screening cases compared to diagnostic cases increased dramatically over the years. Creating networks of champions, particularly at community level. We have succeeded to position breast cancer as health and social priority, and we try to provide always data, reliable and timely data. Factors of success, let's say the political support. We work closely with the government of Jordan, with the Ministry of Health. This political support is important, as is needed in any cancer control initiative. Having, as I mentioned, evidence-based programming. Everything we do is based on studies, based on working directly with the community, qualitative and quantitative research. Based on this, we build our plans, we build our work plans, and we start implementation, continuous monitoring and evaluation before, during, and after the implementation. As I mentioned, customized and tailored, context-tailored strategy and community involvement. We work with the community, with the women themselves, reaching them in their areas. There are some challenges for sure. Cancer prevention and early detection, particularly breast cancer, if I may categorize the challenges, there are challenges related to the health system itself, particularly fragmentation, particularly lack of interest maybe in early detection. Our health system is more towards curative care, but we have managed this through working closely with the health system, through getting buy-in of the government and working and training healthcare providers. The other category of challenges is related to the culture and related to the community itself, particularly stigmatization of cancer or a fear from early detection, but also we have managed with direct work with the community to mitigate all of these challenges. And also for sure challenges related to limited resources, but through networks, through partnerships, also we're managing to get more resources and we're managing to work across different systems. So overcoming the issue of limited resources. This approach has been successful from rural to urban areas. Community-driven efforts have led to increased screening rates. It improved treatment outcomes and reduced breast cancer mortality in Jordan. These are some of our achievements, reaching directly to women, providing free screening for underprivileged women, having more than 95 breast imaging units and thousands of public engagement awareness, more than 17 national and regional campaigns.
Sorry, Ms. Reem, if you can just wrap it up. Okay, good. Okay.
I'm wrapping up. Thank you,
Okay.
Dr. Hadi. Exactly. It's like I
The
make
same
sure to
minute.
have 5 minutes.
Thank you so much, Ms. Reem, for we're all in the region proud of the work of the Jordan Breast Cancer Program is doing, and we're proud as Qatar and I think many of the call are member on the Arab, all collaborating in the Arab campaign of the breast cancer awareness. So but what stand out of all the strategies, what you mentioned, Reem, is the data, and I think this is something we can really point out, that the importance of data for advocacy, for progress evaluation, for monitoring evaluation, for continuous development. So we admire the robustness in collecting data and basing everything on data. So thank you so much, Reem. And now it's my pleasure to introduce Ms. Ikram. She's breast cancer survivor, founder of NABAD. NABAD mean pulse for breast cancer women or women living with breast cancer in Morocco society. Now all floor is yours, Ms. Ikram, and my question is for you as someone who has experienced breast cancer firsthand. What do you perceive as a critical needs for improving cancer screening and early diagnosis, and how have you incorporated those insights into the activity of your organization?
Thank you, Dr. Hadi. Thank you, dear panelists. I am honored and pleased to participate in this great discussion and learn from the experiences of the others. Thank you, Dr. Ibtihal, for inviting me. So without delay, as I know Dr. Hadi is a very strict moderator, so I'll start directly with sharing from patient perspective the critical needs for improving cancer screening and early diagnosis from my own personal experience and also from the experiences of the women that I do accompany and that we have in our association. So the first, I think that has been mentioned already by other persons in the region, which is stigma and fear. We know that, for example, the cultural barriers that we have, sometimes you have very, very successful and effective campaigns organized by the government, but then you don't have the readiness by the women to go for early detection because of these cultural beliefs and barriers, especially when they fear that diagnosis will lead to some stereotypes like reduced and diminished femininity, or they fear like society marginalization, the fear of losing family stability. Sometimes even the diagnosis and detection tools are not very comfortable culturally speaking. Let's talk, for example, just give example of mammogram or pap smear for cervical cancer. So these can push some women to like evade early detection. We also have the problem of resources, especially financial resources. Of course, there has been a lot of efforts to provide some free tests and free screening tools in Morocco, but then we don't have equity, for example, in some geographical areas where you have remote populations. They do not have access to centers where they can get free diagnosis or free detection or screening tools. So there are also socioeconomic factors or family constraints, like, for example, you have moms who do not have who to leave their kids with to go for another, for example, move to another city to get screened and so on. And also we have some like ignorance issues. And when I talk about ignorance, I can stratify or classify that into 3 elements. Number one, we don't have some health literacy consistent programs, because some people are not aware of symptoms, and others are not aware of the existing risk factors, and others are not aware of prognosis possibilities and potential. You know that there is a big difference, a huge difference when cancer is diagnosed at early stages compared when it is diagnosed at very late or advanced stages. But then just the idea that cancer is equated with death may be like losing the enthusiasm to go and get screening in the first and early signs. We also have the problem of not monitoring or not knowing how to do self-initiated detection or self-breast exam, or we do not have access to genetic risk assessment, which is important for early detection, I believe. We also have, in terms of ignorance, ignoring the patient navigation. Pathway, like where to start. Sometimes you don't know where to go first in the first step, because we have different centers. Diagnosis centers are different, early detection centers, and some people get just lost in the meantime. You know that the WHO has recently published WHO, I think, breast cancer navigation patient navigation guideline or toolkit to help with that, assist with that. So we need like capacity building program, and we need more data to know about the difficulties of people to have patient navigation difficulties in Morocco. And also we have ignorance about some administrative procedures, like including how to register to get insurance, for example. You know that in Morocco there has been a very huge, reform in the healthcare system, and this has resulted in a transition from a RAMID, what is called RAMID form, to a mutadammun form, which is a form of insurance that is aspiring to ensure universal health coverage for all Moroccan population. But the administrative procedures to get registered, like in digital literacy skills to get into the platform and register information, has resulted in some people getting simply uninsured, and it is difficult for them to pay or to insure the costs while they are still uninsured or not covered by medical health insurance. Now, concerning our efforts as an organization, we have concentrated on doing workshops, especially with healthcare professionals or with people like academia, to work on the stigma, to change people's perceptions around cancer. We also work through campaigns. Sometimes we use our own campaigns. Sometimes we work in collaboration with Ministry of Health or with pharmaceutical industry or with voluntary HCPs or healthcare professionals who provide help and accept to move with us to go and look for women, especially in remote regions, and get in touch with them and explain things to them. We have some awareness days, and we visit, for example, people at schools, and sometimes even at people gatherings like in mosques, so as we can gather women and talk to them and introduce things to them, the importance of early detection. Now, we also work on orienting services. It means in coordination, especially with government centers, we show them where to go first, which centers are available to them in the regions, which services are provided for free, so that we encourage them to go for early detection and diagnosis. I will conclude with some recommendations that I have noticed from the work on early detection and diagnosis. So it's true that we have very interesting initiatives, especially in October. Maybe we didn't talk about November, which is like Women Men's Awareness, Cancer Awareness Month. But I think that we should think about having a year-round calendar and not be restricted to occasional campaigns. We should raise awareness more about modifiable risk factors, healthy lifestyles. We should implement some strategies, because in Morocco, like, we have a lot of regulations on smoking, but they are not really applied in the field. And we should explore the use of technology, and like it was said before, sending messages through applications like WhatsApp or whatever. We need to enlarge the scope and include some people from the media, some people who are like celebrities and influencers to get into these campaigns. And to conclude, we should foster collaborations and partnerships and the sharing of best practices, not only at the local level, but at the regional, I mean EMR region, and also worldwide. Thank you.
Thank you, Ikram. Thank you so much for insights and how that led to guide you in your the organization work. And now I will, pass on to Dr. Sausan, as we don't have any. I mean, unless there is a burning question, maybe Dr. Sausan will lead the answering for those questions. And it's my honor to introduce Dr. Sausan, and she will lead for the closing remarks.
Thank you, Dr. Hadi. What an excellent and energized panel. I wish we had more time. I think there is lots to be said in this panel, especially early detection. I believe everybody on this panel are passionate about it. I would like to thank Dr. Ibtihal for her leadership and for this amazing series of webinars that has been conducted by the Eastern Mediterranean NCD Alliance, alongside, of course, the London Global Cancer Week. I will start with reflecting on what Dr. Ibtihal said. We all agree that early detection is important. I think right now some of us have matured when it comes to the program. Either it is population-based, sometimes we have community-based, sometimes it is early detection versus, of course, the awareness. What I took from Dr. Ismas is two things. Actually, his presentation was amazing, well structured, nothing to be added. But really, the wealth of documented knowledge that the WHO has, especially in our region, is very important for us as patient organization to look into and really utilize and make for us to understand better how to advocate within our community. That's the other thing, which was echoed a lot, even with Dr. Reem's panel. I think Ikram mentioned it as well, is the influencers. Let's tap into that. And he mentioned really great example of, royalties, wives of presidents that can also help. And even on a community base, we can have those influence. I think Dr. Reem panel was amazing. I think you had, the high, middle, and low middle income countries all together, and they're all talking about their experience. Egypt has an amazing experience. I always say, if Egypt can happen in Egypt, we can learn a lot. The use of ROI is very interesting to me, because I remember even back then when I was still running Friends of Cancer, I used ROI a lot to demonstrate the effectiveness, and I think that is something we all should start doing. I think Dr. Deborah was right in saying public-private partnership. I always add 1P, which is for patient, public-private patient partnership. And this is where we have, as advocate and patient organization representative, have to really engage, not just with the private, but also with the public sector. Dr. Noreen, cervical cancer, amazing work in Pakistan. I think, again, the word stigma and the word shame and the empowerment of primary healthcare to take over that role of screening and understanding how to communicate with the community. I think that is very important. I would also reflect on Professor Samar. She mentioned the data, very important. I believe the data was echoing all over this panel. And of course, Dr. Hadi, amazing discussion. I loved all the opportunities. I think what resonated with me, and I think that's a learning point for me personally, is when a policymaker like Dr. Lubna was saying how they are really tapping into the community and building a better universal health coverage system in Morocco. And of course, Dr. Reem, you reflect on the challenges and the enablers was amazing. I think we all, I personally think that Jordan Breast Cancer Program is one of the most amazing program in our region, and all of us should learn from it. And of course, Ikram, the amazing Ikram, I always love when she reflects back on the actual things that we as patient advocates see in our patient and our community, especially the stigma, the fear, but also the issue of the navigation, which is also an important issue. I think this is a great opportunity. We are all learning from each other. And I would like to close now and over to Dr. Ibtihal for the closing. Thank you very much.
Thank you so much, the panelist, moderator, and the speakers. It's really a pleasure having you this year and talking about cancer early detection. Definitely, we will keep our advocacy and we will keep this momentum and looking forward for more survivor in our region. I thank you, the audience, for joining us. Let's take one final photo. So keep on smiling, and thank you all, and have a great night. Thank you. Bye.
Thank you.
Thank you.
Thank
Good
you.
evening.
Bye-bye.